Excellent point. Okay, now I just spoke to a bunch of CMIO friends who just attended the EPIC user conference. There's a tsunami of AI tools that are coming down the pike. I mean, and they are ecstatic about it. How do you approach this?
What you're talking about is the next shiny
way?
object. You and I have talked about this on a number of different occasions. It's the next shiny object. We have to make absolutely sure they don't fall prey to that shiny object.
So I definitely agree. It's a shiny object, but they also happen to be convincing a lot of the buyers in healthcare systems that can significantly transform, reduce clinician burnout, and significantly cut costs, bring nurses back to the bedside. They're shiny for a reason, but I need to train all the nurses to be ready for this tsunami of AI tools that's happening in every corner of what they do.
Athena, you're at the table as a nursing leader. What about the issue of change management, right? You have this technology, the shiny objects. How do you turn early resistance into champions in order to support the adoption of some subset of these tools?
Yeah. So what is it going to do for me, the bedside nurse? How is it going to make my life easier? What problem is it going to solve for me?
Yeah.
And if you can address that, I mean, that's when you get the early buy-in.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malcurry. I'm the Managing Director at Lighthouse Health Tech Advisors. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Today, we're asking a tough question. Why should a hospital's AI strategy start with nursing leadership? Here's the reality. Nearly 70% of healthcare AI projects stall or fail. And it's often because nurses are left out of the process. Ironically, nurses deliver 80% of patient care and use most of the AI tools within their hospitals. Yet nurses aren't included in the planning, the selection, and the rollout of these tools. A 2023 HIMSS survey found that only 1/3 of nursing informaticians interviewed feel ready to lead an AI initiative. And that's why this episode is about putting nursing leaders at the center in helping develop an AI strategy. Nursing leadership can spot risks early, they can demand ethical and results-oriented tools, and they can help hospitals adopt AI in safer and smarter ways. So to help me unpack this, I've invited three incredible nursing informatics leaders. We have Dr. Jing Wang, the Dean at Florida State University College of Nursing, where she's a nationally recognized expert in workforce development and connected health. We have Dr. Athena Fernandez, a Senior Director of Clinical Informatics at Penn Medicine's Chester County Hospital, where she leads efforts pushing nursing innovation and improving digital care delivery. And finally, we have Troy Seagondollar, a former nursing informatician and leader at Kaiser Permanente, where he was known for his abilities to bridge frontline nursing with technology and advancing digital bedside tools. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. So with that, why don't we dive in? Troy, don't get too comfortable because I'm going to direct the first one at you. Troy, you've seen how frontline nursing leadership can make or break an AI rollout. Sometimes it's the difference between success and failure. Can you share a moment when nursing leadership saved a project or prevented a disaster?
Yeah, actually I can. At Kaiser Permanente, we use the EPIC system, and EPIC was pretty forward thinking in regards to predictive analytics, right? So one of the things we began to work with them on was looking at how we could actually extract different pieces out of the EHR, not only clinical documentation, but lab results, vital signs, and bump those up against our sepsis risk scoring tool. And that worked very, very well. There was a lot of nursing intervention, and it helped them to not miss things. So we took it one step further and we said, okay, well, let's go ahead and let the system actually place the orders on behalf of the clinical staff. That's where we ran into huge problems. The nurses quickly raised concerns that not every alert meant sepsis. So the feedback allowed Kaiser leadership, I was one of those people involved in kind of the decision-making chain, to look at this and say, wait a minute, you're right. We need to step back. We need to actually bring this back in. The tool itself worked very, very well. But again, removing that clinical judgment out of that whole schema caused a lot of issues. So we took it back. And to this day, we still don't actually have full AI. It's more of an augmented intelligence instead of artificial intelligence. Another thing that we actually introduced later on, which was acuity staffing tools. In staffing, you have to kind of predict what the patient status is going to be, and you have to allow fluctuations in staffing. Nurses are skilled at many, many different things. However, not every nurse is able to take care of a critically ill patient. So that led us down the pathway of using augmented intelligence, which would present the data to the charge nurses to allow them to actually assign different people based on the complexity of care.
Hey, Troy, let me pivot to Athena. Athena, you've led teams involved with AI and other types of projects involved in nursing. Can you tell us about a success story or costly failure when nurses were left out of the process?
So you really want to know nursing input right from the beginning. And it's not just the frontline nurses, it's informatics. Because nursing informatics and clinical informatics really bridges that gap between IS and the clinical staff. So let me give you an example of our augmented response technology, where a patient may send a query to the physician, and then the physician's going to respond. There's technology out there where the AI is prompting or drafting a response so that then, you fill in the gaps and it facilitates an expedited response. You want to make sure that that response is speaking in the voice of the clinician that's actually responding. So it could be the physician that the patient may know very well and say, you know what, this doesn't really sound like my physician in their response. It could also be another healthcare provider like a nurse who is responding to that message. And then is that response that's drafted and that's used as the initial prompt through AI, is that speaking through the scope of practice of a nurse?
Okay. Then let's get you involved. From your national work in digital transformation, when nurses are at the table, how does it change the overall design and outcome?
Yeah, I think we hear this a lot. Nurses need to be at the table. I'm glad to hear, Troy and Athena both speak to that. And I think it's just so important when you talk about, AI systems, informatics systems, the largest user and consumer are nurses. So I think we have just seen again a repeated failure when nurses were not at the table. For example, the sepsis example is widespread. We have invested so much money in the sepsis risk prediction. However, research find that it's actually not accurate, which created a lot of, anxiety, burden, and just strain on nurses who are implementing this every day. And I think with sort of all of the newer systems, there are some, promises. I think there are some recent studies that have found some of the systems that are using nursing notes that incorporated nurses from the beginning as they design these AI systems. They consider the workflow of the nurses has shown and proven to be effective, but majority of the AI systems that are currently implemented do not have any evaluation or monitoring plan in place. And I think that's sort of the risk that we are running when we don't see nurses involved from the beginning.
Troy and Jing, when nurses are involved from the start of a project, what are some of the hidden costs that may show up as it relates to financial waste, workflows, trust? What are you finding?
Yeah, I mean, I can speak to that first. And I think the trust issue is significant, right? There are this sort of perceptions that nurses are fearful about technology, anti-AI. And I think it happens because nurses had a lot of bad experiences that are taking them away from the care that they would like to provide to their patients. Some famous videos about sort of initial implementation with some of the initial participants, nurses from the intensive care units are crying that they want to take care of the babies in the intensive unit, but with the first implementation or deployment, they're not able to get what they need in order to, deliver the care and pay attention to the babies, to their patients. And I think that's what frustrates nurses. Nurses spend like more than 50% of their time in front of a computer nowadays. I think it is significant cost when we're saying we don't have enough nurses. Yet
Yeah.
we take all the nurses' time to be put in front of the computers and be struggling with the systems that just don't work with the workflow. All the healthcare systems are telling us we need you to train more nurses from a nursing school perspective. But what we have find is that it's just sort of big black hole that we will never be able to have all of the big number of nurses that we predicted that we are short. And it's not local, it's not regional, it's national and global shortage. So we really need to think about how we should better design these systems to address all of the losses that we mentioned, both from the human factor, the trust factor, the financial factor, and also we may end up having a country that we don't have enough nurses to take care of all of the sick patients.
Athena, at Penn Medicine, how are you looking at some of these issues? Any particular issue come to mind? As I know
Yeah.
you're involved in a lot of initiatives at Penn Medicine.
hmm So it starts with understanding the problems, right? So we have a clinical informatics council where we have nursing representation from every clinical area, and we meet once a month and we talk about challenges and issues that they face, and then solutions that, ideas that they bring to the table as well of things that would work, or things in the EHR that are problematic and not as wonderful as it could be or could be improved, and they bring those suggestions to us. So we incorporate that feedback and try to make our systems better. So when we're looking at any kind of technology, AI or otherwise, understanding those problems and those challenges at the bedside is essential. So I think right now, it's like the .com of like the 2000s, lots of ideas, lots of solutions, and vendors are coming to us with solutions, but what problem is it addressing? Are you saying, here's a solution, now find the problem it can address? One of the other things that we are doing is leadership rounding. So I round with our with my IS partner. So actually being in their space and observing what it is that they do rather than waiting for a ticket to come in, you can uncover a lot of things that really can facilitate and streamline processes and identify issues to then come up with solutions.
Outstanding. Just out of curiosity, at Penn Medicine, do you guys have a framework in particular for AI, the use of AI tools? Has that changed the paradigm around? Because Jing, if I'm not mistaken, you're actually developing a national framework for AI. I might be misstating that, but
Yeah, yeah, that's actually we're launching sort of the Nursing and AI Innovation Consortium in 2 weeks, and part of our efforts is to kick off sort of the development of a national framework that will be supported by a foundation to develop this. There has already been one done in medical education practice, and I think there's an urgent need where there needs to be a guiding framework for nursing across the entire spectrum from education, practice, research, but also innovation and entrepreneurship.
how will we see this introduced? Like once you come out with it, is there a long transition from academia into mainline practice at leading academic medical centers? What does that look like?
Yeah, so we have been, of course, having a lot of different professional nursing organizations in the different areas, lots of schools of nursing, leading healthcare systems sort of joining us in this movement. There are a lot of nursing pioneers, and you're looking at two here that already have a lot of lessons learned. We would like to see, like, we want to move away from sort of an academic exercise to see, hey, this is sort of a call to action. There's a lot of focus on physicians or others where nurses being the largest consumers sort of haven't seen much because we sort of have lots of different organizations representing the large nursing community. So how can we come together and sort of have that authority voice in guiding people who would like to follow, who would like to learn more about how to deploy AI, from Kaiser Permanente or Penn Medicine's experience. So The framework will be sort of initial blueprint, but there will be implementation toolkits to kind of move sort of the field forward. And that's why we need a consortium, because it's not going to be a one-time document. It's going to be a continuous effort in kind of just elevating sort of the nursing profession in the landscape of AI, and also kind of giving specific tools and support for nurses working in the different settings to be prepared for this transformation that is not coming, it's already here.
Now, I want to bring this back to Troy and Athena. So what do you think about this? Some of the framework coming from academia, how might that work into the work you're doing at Penn Medicine or at Kaiser? How is that stuff received, and how is it actually introduced into nursing informatics practice as you're looking at this emerging technologies?
I can start. I appreciate the effort you're putting forward, Jing. It's very powerful. I mean, you do need to have those high level discussions. The one thing that always kind of perplexes me is right now we're talking about you got to get nurses in early. Now, as we all know, I mean, there's a number of different layers of nursing, right? So I am the biggest proponent of the clinical nurse, the one who's actually standing at the bedside, working every day, trying to deal with the system while they're managing the patient and processing all of the different things that are coming through onto their lap. So my question is this, and I always have a concern when somebody says, yeah, we're going to have a consortium and we're going to bring, leaders in and things like that. So can you help me understand in this consortium, who's actually being invited? And are they a mainstay instead of just kind of like a sidebar conversation? I'll take that back to my nurses and we'll have a round table and talk to them about that instead of bringing them forward. And let me tell you why I'm so dead set on this. I mean, I was part of a federal advisory committee for health information technology a long time ago. The reason I was in the room is because I represented 138,000 clinicians while I sat in that room. And at times, even the ANA, when they approached me, they said, no, you actually represent the 4.3 million nurses who are out there dealing with health information technology on a daily basis. So can you help me understand?
Yes.
Maybe you too, Athena.
Yeah,
I mean,
of course.
you're also an academia.
Yeah. I actually want to correct Craig. It's not from academia. I know I have a dean's title that because I am from academia, but I can share with you American Nurses Association, now the American Nurses Enterprise, actually is a founding member of the consortium. And there are, from the healthcare systems perspective, I'm one of the 3 co-founders. We actually have one co-founder who's an innovator and entrepreneur, so a chief nursing officer from an AI company. For example, companies like Microsoft, but also some AI startup companies out there in healthcare and focus on nursing. But another important piece is we'll have healthcare systems such as Cedars-Sinai, Mayo Clinic, and Emory Healthcare. So these are the chief nursing executives, but also kind of nurses, nursing innovators in the practice settings. And our initial partner actually is Coalition for Health AI. CHAI is an organization that also has both the industry, healthcare system, and also academic medical centers are part of that coalition. But trying to find one entity, like, is it American Nurses Association? Is it American Academy of Nursing? We have many, many nursing organizations that represent different areas of nursing. So our goal of having one consortium is to make sure, all of the nurses in different settings will have sort of a representing voice, both from the organization that they belong to or the different stakeholders across sort of the healthcare landscape, from education to research and innovation.
Wow. Now, I want to just bring Athena into the grad. Athena, as a nursing leader at Penn, how are you reacting to this whole idea, this framework that's being developed? How might you bring that into some of the strategic planning that you're doing as a nursing leader?
So whenever we start anything new, we look to what's the evidence out there, what's already in the literature. So that's where I would start and bring in what Jing and her team have built, and then go from there. Can we apply this? What tweaks do we need for our population or our healthcare system that, you may not just be blindly able to adopt it. You may need to tweak it a little bit for our audience. But that's where we would start.
Great. All right. Thanks, Athena. All right, Jing, don't get too comfortable. I'm going to direct this at you. From what you've seen on a national level, are there specific habits or traits that set the AI savvy nurse leader apart from the rest? Who are those early adopters, those innovators that are really to embrace the framework that you're putting together today?
Yeah, I think what I notice is people who have the skills to navigate in a interdisciplinary collaboration environment. It's some of the IT kind of informatics savvy nurses is they can speak the language of IT and they can speak the language of healthcare leadership, business. So these are the people, not just because they're nurses, they're invited to the table, but because they are able to add value to sort of the healthcare team. And we talk about KPI because different kind of areas of healthcare speak different language. It can be from an operation, from an executive leadership perspective, from a financial perspective, from a workforce, and from, the staffing perspective. I think
Great.
that's overall where I have seen the success of nurses who are invited to the tables and then can sort of elevate and represent sort of the nursing community in the bigger healthcare and AI space.
I'm going to turn this over to Troy and Athena. For nurse leaders who might feel overwhelmed by AI today, what's an immediate step they might take in order to start owning the strategy or at least being part of the strategy?
I'll let Athena speak for now, and maybe I'll dovetail off of what some other thought.
Yeah. A couple of things you can do is educate yourself, understand the terminology, understand just basic what is AI. Some of the things that can trip you up is what data is used to train the AI. And then how is the AI coming up with the conclusions it's coming up with? So understanding some of those nuances kind of sets the stage for asking intelligent questions or asking questions when you're evaluating a tool. But understanding that terminology, understanding those concepts will set you apart and have you come to the table with questions that are meaningful and thought-provoking.
Excellent.
I
Troy,
think
what do you
that-
think?
I think
Obviously,
just to dovetail off of one key point she brought up, it has to do with really understanding what are we talking about. And I'll go right back to what I was saying at the very beginning. There's a huge difference between artificial intelligence and augmented intelligence. And artificial intelligence means that the machine does everything. There is no clinical judgment involved. That right there is the biggest crux I think that we need to talk about. We need to make absolutely sure that people understand. At this point in time, because we're talking about humans, we're talking about the massive amounts of liability that are involved in this. So I move again over to augmented intelligence to say, look, it's not deciding for you. It's giving you the tools you need to make the right decision. That's the selling point, and that's where we need to go. So if nurse leaders are struggling with the difference between artificial intelligence, well, it's going to do it for me, versus augmented intelligence, where it's going to assist me in making the right decision at the right time for the right situation, then I think we've got a viable solution to a lot of the issues that we deal with. Missed diagnoses, missed treatments, missed cancers, right? We're even looking at the cellular level and evaluating that stuff. I think that's probably one of the biggest things that Watson did early on, was the ability to look at all of these different radiologic studies and say, well, there's a missed tumor, and then looking at the lab values and saying, yeah, based on that, this is 99% positive for being a something that needs to be treated, something that needs to be evaluated further. So I think that's really key. That's what we got to look at. Now, I think
excellent point.
in terms of who actually needs to be at the table to discuss those things, when you start talking about the modification to workflow, gotta have bedside nurses at the table. You really do. I really appreciate what managers and directors and CNIOs and all those folks do. For the longest time, I was at a very high level. I actually left a very high level national position with Kaiser and went back to the bedside because after we had implemented the Epic model, I said, I got to go back and see what we did. It was profound. Oh, it was amazing. The learning that I got out of that, because the nurses kept complaining that the system was too difficult to navigate. I went back and I learned about that. But again, having those bedside nurses at the table is of paramount importance. And I really, really stress it. And I'll give it back to you, Greg.
Excellent point. Okay, now I just spoke to a bunch of CMIO friends who just attended the Epic User Conference.
Mm-hmm.
There's a tsunami of AI tools that are coming down the pike. I mean, and they are ecstatic about it. From a nursing leadership perspective, how do you deal with it, right? So it's not just a trickle anymore. Now it's massive numbers of tools that are being introduced under the Epic umbrella. How do you approach this?
What you're talking about is the next shiny object.
Way?
You and I have talked about this on a number of different occasions. It's the next shiny object. We have to make absolutely sure they don't fall prey to that shiny object. Look at what I found. Look what I got. And they just throw it out there, right? It's okay to be intrigued by that, to look at the innovation and bring it back. Share it with the nurses on the unit and say, you know what? They've got this new thing. Let's give it a try. But remember, you have to engage them and you have to give them a platform in order to give you that feedback. Not every shiny object is the thing that's going to fix all your problems. And we fall trapped to that a lot of times.
No, I totally buy that. And I agree with that. But I want to get back to Jing here. So she's developing a framework. So you have two things going on: the practicality of how do you introduce this stuff, but also the tsunami of tools that are the next panacea. Is that part of the overall vision? And in what time frame do we actually introduce these technologies, or expect to introduce them at the bedside? Does it have to be in a very methodical way? Is there I'd love to, if you could just elaborate on that and how this is going to go into practice.
At this moment, I don't think nurses have a lot of choices. That when it is decided by the executive to implement these AI tools that they believe that will cut costs, and can streamline the system, nurses gotta do it. That's happening in majority of the cases. I definitely agree. It's a shiny object, but they also happen to be convincing a lot of the buyers in healthcare systems that can significantly transform, reduce clinician burnout, and significantly cut costs, bring nurses back to the bedside. But again, all the lessons learned that Troy and Athena both have shared that don't work. I think, yes, we would like to, go through, I think the pilot testing cycle, and I think Athena and Troy are probably expert in that area, is really important. We're also advocating with our partnership with the Coalition for Health AI is to kind of educating nurses about more like a nutrition label for AI systems, so you will understand what's the data that we use to generate this AI system, and educating nurses about how these predictive algorithms were developed, what are some of the potential hallucination, biases that may exist based on how it is developed, and develop specific AI governance kind of models so that the bedside nurses know exactly when they are confused. Do I follow what AI is telling me, or do I trust my own clinical judgment? I think these are the things that we are sort of looking at, both from a clinical perspective, but also from my perspective, I need to train all the nurses to be ready for this tsunami of AI tools that's happening in every corner of what they do. And how can we prepare them?
No, excellent point. Athena, what do you think? All right. So Jing raised a really interesting issue, right? There is a tsunami of stuff coming down. There is an Epic first strategy. I know Penn Medicine is a Epic shop. Executives make this investment. They said this is what we're going to deploy on a system wide basis. Where does that leave some of the nursing leaders? Do they have a choice in how and when and how quickly this stuff gets introduced?
Yeah, we absolutely need to have a seat at the table, and we do. Getting that, so it goes both ways, right? So you're taking the input from the frontline staff, you're understanding their problems, and you're taking that feedback back. You have a governance structure. As Jing said, we have a local governance structure. We have an enterprise governance structure, and when we are a seat at that table, you are the voice for your entity, and you're taking the feedback based off of what you're seeing, and you're discussing locally and then taking that feedback back. So yes, we do have input, and I think you need to be ready when you're asked for that input to give that input. So that's critical. And if you don't have a seat at the table, to ask to be invited and get a seat at the table. and make your voice heard. I think is
All right,
essential.
so I think that you're at the table as a nursing leader. What about the issue of change management, right? How do you address the issue of change management with the staff nurses, right? You have this technology, shiny objects. You've been told that you need to introduce these technologies. So how do you turn early resistance into champions in order to support the adoption of some subset of these tools?
Yeah. So what is it going to do for me, the bedside nurse? How is it going to make my life easier? What problem is it going to solve for me?
Yeah.
And if you can address that and say how it's going to decrease steps, it's going to take away some stupid thing they were doing before, or, solve a problem that they've had or a thorn in their side. I mean, that's when you get the early buy-in and then involving them throughout. So at each key step, what do you think about this? We're adding this, we're taking, we're doing this. What do you think? And getting that feedback. And again, I said, that's why that informatics council that we have, where we get that input and that back and forth. And because we've established that structure, then we have developed that relationship, not just with our nursing frontline staff, but key people on each unit, right? So now they're learning to speak that technology, clinical technology kind of terminology. So when they see something, they'll just text messages, securely through the system. Hey, we are seeing this. So they have that connection and we have that back and forth on a daily basis. So we really have a good pulse of what's going on at the front line, which I think
Okay. Troy and Jing, how can nurse leaders build real trust around AI safety and bias? I think Jing, I think you brought up that issue around hallucinations, right? Which is a real issue. So how do we build trust around these issues, right? That this is guiding nurses or other members of the care team effectively.
I think transparency is very important on how these AI tools were developed and understand how best to implement and deploy the systems, and having the nurses who have the knowledge, the literacy, and the skills to, be part of this interdisciplinary team for deployment and implementation, or, go all the way back to the design the system. It's very important. It's also important to also continuously monitor and don't just stop at the deployment, but throughout have a continuous improvement plan to make sure that, the augmented intelligence piece actually works and actually produce the outcome that is supporting the nurse's workflow and bring nurses back to the bedside.
Well, Troy, this kind of relates to the issue you brought up earlier about the confidence in the tools. How well does this stuff have to be proven out before you're really ready to deploy it en masse across multiple sites and across a bunch of nurses at the bedside?
Well, I'm pleased to hear that Athena is utilizing informatics councils locally, and I'm hoping that embedded into that is a group of bedside nurses from every unit who share information and data across the spectrum as the patient transitions through the levels of care. So the whole informatics council, I mean, you got to remember, informatics is pertaining to information. That's the basic foundation of it. Now, how we share that information is what the EHR has helped us do. So it is an adjunct in and of itself. It used to be a paper record or a verbal report off. Now we have other tools that we can actually see those things. So that's good. That then takes us right into the adoption versus adaption issue that we've always had. Nurses don't adapt well. They adopt if indeed, to Jing's point, it helps solve a problem. Once you've done that with that augmented intelligence piece and they become more comfortable with the data that's coming forward and you can manipulate it, you can actually refine it a bit, then we have a really strong case to move into artificial intelligence where they say, you know what, 99% of the time I look at the alert, I actually click on accept and it sends all the appropriate orders. 99% of the time, it's absolutely right. That 1%, there's not a lot of liability held with that. That's how it's got to evolve over time. If we begin to talk about artificial intelligence, we're going to scare a lot of people. We have to make absolutely sure that we let them know, no, the system's not making the decision. We haven't removed you from the equation. You are the last step in all of these different things, but we want to make absolutely sure that we're doing the right thing at the right time for the patient and we haven't missed anything. So then they begin to adopt it.
I think you're raising a really valid point about this whole idea of intimidation, right? I guess if you push too much on. Jing, as you're looking at your framework, are you thinking about these types of issues, this adoption versus adaption, the idea of are nurses really ready to take on take on these tools, and in what time frame?
I think nurses are ready, and nurses are the best people to assess the readiness of the
Yeah.
AI tools. Like we all mentioned that we know when something works, and that's why patients can't trust the nurses and nursing profession. I think there needs to be more education and training, not just sort of in schools of nursing, but also for the current workforce. And I think a lot of nurses are hungry for this knowledge. We may not be able to produce the number of nurses that we need to address the nursing shortage, but through training of the current workforce and better train our future healthcare workforce nursing professionals, I think we can figure out a way to reduce the administrative burden, reduce your documentation burden, and reduce burnout among nurses. But it needs to be done right and with nurses leading the work.
Let me turn to Athena. Athena, what do you think of that? That sounds really compelling. But you're on the front line. What are you finding
Yeah.
as a nursing leader at Penn?
Yeah, I'm seeing there's some fear, fear of losing jobs, of losing their jobs. So understanding that you're not losing your job, the way you do your job may change, right? The tools you have in your toolkit will change. So it's not, we need all the nursing help that we can get. So that's one piece of it. And the other thing is we have not talked about the patient, right? How do we prepare our patients for this change? How do we involve them, their patient experience in notifying them that, hey, you know what? In this process, AI was used for whatever. So Jing, do you know, as part of your consortium, is there any focus on the patient and the patient pieces and how that'll play out?
Yes. So I didn't mention those, but we do have patient advocacy organizations as part of the Coalition for Health AI that we were part of. Kind of the coalition on how we can incorporate some of the patient advocacy organization. There are specific ones that we can partner. We often sort of try to position nurses as the patient voices, but I think you bring up a really good point is that when nurses are using the AI systems interfacing with the patients, how do we prepare the patients to understand, the care that they're receiving is augmented by some AI systems.
Well, guys, I think we're out of time. This has been really illuminating. I'd like to thank Troy, Athena, and Jing for your candid insights. Three bold takeaways I've gotten is one, I think organizations need to own the AI agenda. Don't wait to be invited. Lead now to protect patients. And most importantly, getting nurses involved at the table. Start small, which I think we're doing, but we need to make one first step. And I think that it needs to be very thoughtful, as Athena had pointed out, and evaluate different options, and also lead with ethics, right, around safety and fairness. But I'd like to thank you all for joining Beyond the Blueprint. We look forward to seeing you again next time. Oh, thank you very much.
Great.
Okay,
Thank
great.
you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.